This is a case of leiomyoma of the esophagus. Actually, this patient presented with difficulty in swallowing, and there was a large submucosal swelling which was confirmed by endoscopic ultrasound and CT scan. So patient we are operating. This patient is in prone position. We are inside the right pleural cavity, and we are actually incising the pleura overlying the thoracic esophagus. You can see the azygos vein, which is causing the tracheal bifurcation to enter into the superior vena cava. We have insufflated the right pleural cavity with carbon dioxide. The pressure is 8 millimeters of mercury. So now we make only pleural incision with the help of hook and monopolar energy. The collapsed lung is lying below. We can appreciate even the right bronchus getting distended with each inspiration. So the vagus nerve and other neural structures which is actually running on the esophagus should be preserved. Now we are going to ligate the azygos vein because the tumor was situated exactly behind the azygos vein. So unless the azygos vein is ligated, then it is very difficult for us to approach the tumor. So we are actually going to ligate the azygos vein. That is a nerve. Once the azygos vein is ligated, then we encircle the esophagus at one level. Then we will introduce umbilical tape to go around the mobilized esophagus. And if you pull the umbilical tape, it will expose the plane for dissection. So whenever ligating the azygos vein, always ligate proximally, then come distally. Because if you put distal ligation first, the azygos vein will get distended grossly, then it is very difficult to ligate further. You can use even stapler to divide this. So we always put 2 to 3 ligations on either side, and sometimes we use additional clips also, so that there will not be any slippage of the suture or clips. We put a gauze piece inside, so if there is any bleeding, mild oozing, it can be cleaned now and then to keep the field dry and clean. Now we have done a incision over the tumor was lying on the opposite side, that is on the left side of the esophagus. We made an incision to the muscle layer by using harmonic scalpel, and in order to give traction, we have put a stitch to the leiomyoma, and we are using that stitch to give nice traction. Already we have removed 2 tumors, and there appears to be one more tumor. So we are again making a stitch for effective traction, because if you grasp it with the grasper, most of the time the grasper will fragment the tumor. So if you want to remove it in toto, then you can use this technique. Either you can use a stitch, or sometimes after a good mobilization you can even put envelope around the tumor if it is a longitudinal tumor, and you can use that envelope to give best possible traction. So always it will be, the mucosa will be overlaying the tumor, so you have to be very careful and stay on the tumor. Don't injure the mucosa, because if you injure the mucosa, then patient has to wait for more number of days in the hospital. You can see that is the mucosa, and what we are holding with the left hand is the tumor. Sometimes these tumors will go around the entire circumference of the esophagus, and it will cause dysphagia, very high grade of dysphagia. Sometimes these sort of tumors at the OG junction will mimic like achalasia cardia with proximal dilatation of the esophagus, or is called pseudoachalasia. You can see once we put an envelope to the tumor, that gives a very good support for the traction. And the tumor is completely removed. So we place the tumor in an endo bag and we'll retrieve it later. And this divided myotomy will be closed by using continuous absorbable PDS suture, and we'll place intercostal drainage tube and deflate the right chest cavity. Thank you.